Okay, well, let's get started. Now, just to technically, can everybody hear me?
Yes.
Okay. Well, welcome back. And I didn't get an opportunity to introduce Dr. Michael Polikar, so I'm going to do that now. He isn't it? You've already just heard him speak, but he is a professor emeritus from UCSF in OBGYN. And currently he's working very closely with the National Family Planning and Reproductive Health Association as their clinical fellow. He, for a long time, was there's a special title, but he was essentially functionally the medical director of our state family planning program here in California for many, many years. And he's doing that now as well, again. And, and he's under his tutelage, many people within the context of the state family planning program have gotten increasingly evidence-based in their medicine and in the practice. And it is thanks to him that, in large part, and the group that he worked with at UCSF with our state family planning program to make it one of the most incredible family planning programs in the country. He's also a senior author of the book Contraceptive Technology, and we're now in our 21st edition. And he has been on expert panels. He just talked to you about the CDC guidelines, and he has been on expert panels for the medical eligibility criteria, the selected practice recommendations, and also the quality family planning document that was put out by CDC. So we're going to talk about cases. We're going to use these cases as an opportunity to have a bit of a conversation between all of us as a panel. And hopefully, if you have questions or comments, things to add, please do so in the chat. And Jolie, as Jolie said, she'll be monitoring it so she can bring in your voices too and be more interesting and rich, robust conversation. Here are our disclosures. Mine are the same as before. I work as a consultant and trainer for Sabella, which is a company that has 2 IUDs in development. And I'm a trainer for Nexplanon, and nobody else has any disclosures. We could go on and on with the learning objectives, and we did. A lot of them. So first of all, Anna says, is this bleeding for real? She's 23. She's a cis female. She's had 1 baby, and she has no medical problem. She's been using a copper IUD ever since her son Jack was born 11 months ago. She's resumed menstruating about 5 months ago when she stopped. When she was still breastfeeding, but Jack started eating solid food, so she got her periods back. She's having a telehealth visit today because she's having really heavy periods and she's not sure what that's coming from, and she's concerned. So first of all, I don't know how many of you know about NSAIDs as an antidote to bleeding with the copper IUD, but I would say across the board, and I'm curious, Jolie and Dr. Policar, what you would do, but I would generally, anybody I'm going to be placing a copper IUD in, I will advise them that this is something they can do. They can do this prophylactically. It's just high dose NSAIDs starting a bit before, a day before, 2 days before the menses starts. The NSAIDs will block the prostaglandin release in the uterus, and the bleeding will be up to 70% reduced from what it would have been. The copper does create a prostaglandin effect inside the lining of the uterus, which causes extra bleeding. So this blocks that.
This has been, when I learned about this, kind of a game changer for people who have the Paragard or the copper IUD, because, that's usually the main thing that they, if they have issues with it, it's the bleeding. And so to be able to offer something is huge.
Yeah, the thing I'd add, Patty, just very quickly, is given the fact that you've listed 2 NSAIDs, certainly my preference, both for the cramps, i.e. the dysmenorrhea part, as well as the bleeding, is actually to use naproxen sodium, which of course is available over the counter. The brand name is Aleve, just to see if you're familiar with it, but of course there are many, many generic versions of it. And this comes from really old literature, but there were actually comparisons done of ibuprofen and naproxen sodium, particularly for menstrual cramps, and the naproxen sodium actually than ibuprofen did. So remember that at least for some people, that's going to be a preferred approach.
And it's a twice daily dosing, which is often easier for people too.
Yeah. And you can, a lot of our patients actually have their prescriptions paid for. And so if that's the case, you can just write the generic for Anaprox DS, which is a little bit higher dose it's 550, but it's BID, but it's so much easier for somebody to have a prescription bottle that tells them exactly what to do. And this is a perfect opportunity for teach back. This is the situation where you might say, you know, I've gone over a ton of information and I just want to be sure that I've been clear, rather than asking the patient, tell me what I just told you so that I know that you're not a dummy. So teach back really works well for this because there's a lot of detail. So Anna says, you know, I'm really glad that you're telling me about this wonderful way that I can not have heavy bleeding, but you know, I'd prefer not to get my period at all. I was really happy not getting my period while I was breastfeeding. And, you know, I was using the pill when I got pregnant with Jack and I didn't have any side effects with it. So just to clarify, I'd want to just do a couple of quick didactics because I find like there's a lot of misunderstanding, misunderstanding would be the right way to characterize it, about the various hormone content in combined hormonal contraceptives, pills, patches, rings. I think people often think that the estrogen part of it is the contraceptive effect part, and it isn't. It's the progestin. Doesn't take a lot of progestin in order to prevent somebody from getting pregnant because it thickens cervical mucus. It doesn't even have to suppress ovulation in order to be effective to prevent pregnancy. But the estrogen is added into combined hormonal contraceptives specifically to control bleeding or for one of its non-contraceptive benefits, like to treat acne. It may sometimes assist in ovulation suppression as well. And it will change to some degree how the progestin is metabolized in the body. And I want to just go through a couple of slides. We're not going to do these in depth, but this is so that you have it. And I want to kind of get clear in your mind about the difference in dose of progestin, because the way somebody's endometrium will respond to a given progestin method will in part depend on the type of progestin as well as the dose of progestin. So a minimal dose would be a levonorgestrel IUD, either the 52 milligram or the smaller ones, which will reliably thicken the cervical mucus and reliably thin the endometrium. So it protects the endometrium, creates a thick cervical mucus to prevent pregnancy. Then we go up to a low dose, which is the norethindrone progestin-only pill, which is the one we had on the market exclusively until recently. Now we have also the drospirenone progestin-only pill, which is been shown to have higher, it has a much longer half-life, so you don't have to be really careful to take it at the same exact time every day. The way that this drospirenone progestinone pill is set up, it's set up to actually have a withdrawal bleed, a menses, once a month. So it actually has 4 days where you're actually on a hormone-free interval, unlike with the other progestin-only pills. But that and the implant are sort of mid-dose. And then we get to really high dose, which is the injection with DMPA. And all of these, no matter what the dose of progestin, will thicken the cervical mucus and thin the endometrium. And when we think about the effect that these various doses might have on the ovary, there it becomes really different depending on what the dose is and what the type of progestin is. If with the higher doses, you have ovulation suppression. With lower doses, you don't. So the more progestin you have, the more assured you are that you have suppressed ovulation, if that is your goal. So again, minimal progestin rarely is going to inhibit ovulation, especially with the smaller IUDs, pretty much never. With the larger 52 milligram, sometimes you ovulate, sometimes in the beginning you ovulate less frequently, but in general, you can't assume anybody's ever ovulating, which means that if somebody has bleeding with a levonorgestrel IUD after the first few weeks or months of adjustment, it's likely to be an actual period. And then when we look at the low dose norethindrone progestin-only pill, that sometimes inhibits ovulation, but it's often unaffected. And you may see the person continuing actually to have a cycle on top of it. So you probably all have seen some people get no period at all, and some people do continue to get a very light period. Then when we get to the implant and the drospirenone pill, as well as combined hormonal contraception, they will more reliably inhibit ovulation. Not 100%, but they do reliably inhibit it. And I want to point out that any of the progestin methods or combined hormonal methods up and through mid potency all still allow the ovary to function. So it suppresses ovulation, but there's still some follicular growth. There's still estrogen being created by the ovary. But when you get into a very high dose, like with the injection, the MPA, that's when you start to see not only very reliable ovulation suppression, but also really just ovary suppression. So you really start to see less estrogen being made endogenously.
I think that this is a really helpful slide also in thinking about when we're talking to our clients, especially clients with things like endometriosis or pelvic congestion syndrome, why we sometimes go towards those higher dose methods and why we would recommend those as kind of more preferable, not like exclusively, because of that, like that suppression that's happening, so that they're not like, and so that it's helpful to be able to explain to clients why we might lean towards certain methods over others.
Yeah, I think of the DMPA as the best use of it is actually for its non-contraceptive benefits. So for people with bad endometriosis, et cetera, and all those. So it's a really good point, Jolie. Anything to add, Mike? So why other reasons you might want to suppress ovulation would be treatment of PMDD for menstrual syndrome, and very effective with hormonal contraception. Particularly continuous use, and I'm biased towards continuous use, I will say right out, and so we're going to talk about that in a minute as well. But also reduced risk of ovarian cancer, and that's really with any of these methods, you have the potential when you reduce the amount of times the person's going to ovulate. We think that physiologically what that's going to do is to help protect them from ovarian cancer. So I said continuous use. Continuous use means no placebo. It means they take an active pill every single day, with the goal being that eventually, sometimes right away, sometimes within 3 to 6 months, no bleeding whatsoever. So if you have the pill up on the right here that has 28 active pills, you're good to go, right? You just finish that one pack, go to the next pack the next day, the very next day. But if you have a 21-day pack, meaning the traditional 21/7, 21 days of active pills, 7 days of placebo, 21 days of hormone-free interval, then, or if you have one of the newer pills, which is a 24-day active pills, 4 days of placebo. In either event, all you have to do is just not take the placebos and not have any hormone-free interval. And there you go. It's very simple with the ring that has been out up until, it's been the only ring on the market until fairly recently. The brand name is Nuvaring. Continuous use is very easy with that. The goal is no bleeding, as with any other continuous use of a hormonal contraceptive. And knowing that each ring has enough hormone in it to last at least 5 weeks means that you can feel comfortable with using one ring per calendar month. Much easier to remember my January ring, my February ring, my March ring, rather than 3 weeks on, 1 week off, 3 weeks on, 1 week off. So first day of the month, take your ring out, take out your last month's ring, and the first day of the month, that's that same day at the same time, you just put in the next month's ring. So you only have to remember something one time a month. There is now another ring called Anovara, and these are actual sizes. It's meant to just give you a comparison in terms of how thick it is compared to the Nuvaring, but it is designed to be used for an entire year. And the way that it was approved by FDA was with essentially a 3 week on, 1 week off, kind of the same kind of schedule as you would see with a 21/7. And so we are thinking and hoping that this is going to be an excellent way to do continuous use, but that's not been approved for that purpose yet. Neither has the Nuvaring as well. Either. Comments, either of you, about these things?
Yeah, I mean, I love the month method, I think, or the month kind of approach. The other thing too is if you have someone who does want to have some sort of bleeding, you can also use kind of the calendar method, but a little bit different, where you can put it in on the 1st, take it out on like the 27th of the month, and then put it in on the 1st again. And it doesn't matter how long the month is, because it's never going to be out for more than that week. So that's just another way to do it too. If you have somebody who does want that withdrawal bleed, but wants to remember, this is my January, this is my February, you're still always putting a new one in on the 1st of the month.
And remembering that there's a lot of grace period, because each of those rings has got at least 5 weeks in it. So even if the person forgets to take it out and they're now into the next month, they're still okay. And as Jolie said, you could stop your ring, take your ring out on the 27th. That'll give you essentially a 4-day rather than a 7-day interval. If you're going to have a hormone-free interval, there's really no doubt that a 4-day is better than a 7-day. That's pretty much it's just better. Allows the ovary less time to wake up. You have more of a grace period. Obviously, if we're used to being off 7 days and we're now trying to be off only 4, if you forget and you're off 5, well, you're still less than 7. Sorry. So drospirenone, this is the brand new progestin-only pill. Brand name is Slind. It is drospirenone rather than northindrone, and as I said, it has a much longer half-life. It's designed to actually have a hormone-free interval of 4 days, which is supposed to bring about a bleed once a month. This does actually suppress ovulation pretty reliably. And because it's got a very long half-life, so it's very forgiving in terms of being late on doses. The other thing about this is that this type of progestin, drospirenone, functions in the body. The body acts as if it is somewhat estrogenic. So it is going to be actually helpful in terms of hirsutism. It's going to be helpful in terms of any kind of PCOS symptoms that somebody might have with hyperandrogen state. So this is just it's brand new, as is Anovara is also new in the last year. And in both cases, whether or not you have access to them right now, I don't know, but you will probably be having access to them in the coming days, years, weeks, months. So Anna says, okay, well, that's great. I love the idea of suppressing my period with continuous use with one of these methods. But you know what? I'd really like something I can forget about. So do you think maybe with Anna, if we'd gotten all that information at once, that these were all the things she was looking for, maybe we wouldn't have had to go down the whole line of combined hormonal contraceptive and having a conversation piecemeal about each of the little things that she wants, did you notice that each time Anna you're going down this path, and then she says, well, I want this other thing. And so now you have to go down that path. Each one of those paths takes time to talk about. So maybe you would have saved a lot of time doing it this way. People have a lot of variability in how they feel about their own bleeding. And so that may be based on just personal preference, but it also could be fear or misinformation. It may have to do with, how well they tolerate bleeding or how well they tolerate the fear of pregnancy without bleeding. And these are all very individual factors. So you have to take into account asking somebody, saying things like, many people who use this don't get their period while they're using this method. How would it be for you if you didn't get your period while you were using this method? Anything to add? Okay. So the whole one of the patient-centered ways to talk about bleeding changes is how the method changes the way your periods come. So not menstrual bleeding, not menstrual changes, but changes the way your period comes, just more patient-centered language. As I said, with the hormonal IUD, most cycles are ovulatory, and the effect on the ovary is not very strong. So the person does generally still ovulate, not always effectively, but they do tend to still ovulate almost always. But there is a very pronounced effect on the endometrium, so we see a 90% reduction at 1 year in the amount of blood that somebody's losing once every year. And we say amenorrhea in 20 to 80%. It may be strict amenorrhea, not a drop of blood in the last 90 days for 20%, but really closer to 50. And as they start 50%, and as people use it longer, 60, 70, 80% of people will say, I don't get my period. So it's not strict amenorrhea, but they don't get their period. If you have somebody who's got some unscheduled or unacceptable or unfavorable bleeding, do you or don't you do a workup? You're going to have to really apply your clinical acumen to decide that. It's always in the context of the history of the patient and other symptoms and signs, things like pain and vaginal discharge, postcoital bleeding. You're not going to run all these tests on everybody who has bleeding that is changed or unscheduled based on their progestin-only method. But these are things to just bear in mind. These are all the things to consider, because there's essentially, if you think about making your life easier when trying to figure out if something's a problem, if bleeding is a problem, do I need to work this up? Ask yourself, is there any possibility that what the person has, any reasonable possibility, that what the person has falls into one of these buckets? Is there a possibility that this bleeding represents pregnancy, ectopic pregnancy, infection, upper genital tract infection of all kind can cause irregular bleeding, or malignancy, so uterine, cervical, places that are in the upper genital tract or could cause bleeding that could be seen vaginally.
I was just going to hop in. When people were introducing themselves at the get-go, I saw there were quite a few, I think, nursing students, medical students kind of in the group today. And I think that those buckets are just relevant across the board when somebody has kind of abnormal uterine bleeding. And so we can't forget about those things just because they have a method where like that's an expected thing, especially if there's any sort of change from baseline. Someone's like, oh, I've had the hormonal IUD for 2 years and I really hadn't gotten a period and now I'm bleeding like after sex every time. You can't just be like, oh, that's just an expected, you're having, some irregular bleeding after because of your IUD. You have to use that clinical judgment.
Absolutely. And I just want to be really sure that the message we're giving you isn't that everybody needs a full workup. I hope what you're hearing is that is not the case. But you do need to think about the possibilities. And how do we treat unfavorable bleeding? So for all progestin-only methods, the first line would be NSAIDs, similar to what we described for the copper IUD. The difference being that when you treat irregular bleeding or unfavorable bleeding with NSAIDs in this context, it doesn't need to be 2 days before the menses. This person may not even be menstruating. They may just be having a lot of unfavorable bleeding that's unpredictable. So the NSAIDs that you're going to use for the copper IUD, it's better if you can get them on board a day to 2 days before the bleeding starts. Some things that have been shown not to work, specifically for the levonorgestrel IUD, would be transdermal estrogen. That was looked at in the CHOICE study and actually increased the amount of bleeding because the person used estradiol transdermally in a patch for the first 3 months, and it caused more bleeding. An interesting little factoid, smaller uterine dimensions are associated with more favorable bleeding and less pain with IUD. Very counterintuitive. Mm-hmm. Why does estrogen work for unscheduled bleeding? Well, it does work, and we embrace it. It's a wonderful option, but not for the levonorgestrel IUD. But when it comes to progestin-only pill bleeding or DMPA bleeding, and very helpful with implant bleeding. So it's because it will build a little bit of a lining. The estrogen, as you know, builds the lining of the endometrium, and the progestin will shed the lining. So it'll build a little bit of lining so that there's something for the progestin to actually shed, as opposed to if you are having constant progestin but no estrogen, you just really start to thin out the lining of the uterus so much that you're getting down to the basement membrane, and it starts to sort of just bleed a little bit in irregular ways. And so the estrogen actually helps to stabilize that. At least that's how we think it works. And you can do that in any number of ways. You can use a monophasic combined oral contraceptive, a combined hormonal contraceptive ring, or estradiol in 1 or 2 milligrams, or conjugated equine estrogen in 0.625 or 1.25.
Right. And just a very quick point about those alternatives, particularly if a patient doesn't have any sort of, like health insurance coverage and has to pay out of pocket, that the micronized estradiol, which is the generic version of 17-beta estradiol, is literally pennies a tablet. So, if they don't have good access to birth control pills or some of the other things that are on the list, or have to pay out of pocket for them, then use GoodRx or one of the other products out there that help people get generic medications for very low prices. And you'll find that, 20 micronized estradiol pills is probably not going to be any more than $4 or $5. So it's a good choice if you don't have other alternatives.
So there's treatments that have been looked at. Some of them are actually looking like they work, doxycycline, but only while you're using it. Mifepristone is hard to obtain, but extremely promising data. Tamoxifen is very promising data. but it's a pretty intense thing to do for bleeding, in my opinion. Having tried tamoxifen myself, I would say it's a pretty intense drug to use for bleeding. Ulipristal acetate would be great as well, but it's hard to obtain for even for research purposes. They had to stop one of the research projects that was going on for ulipristal acetate because it wasn't available. And then tranexamic acid, but that's, you know, a 3 to 4 time a day dosing, and it's got a DVT risk associated with it. And then finally, treating with the progestin-only pill. So you're using a progestin-only method to begin with, and then you add the northindrone progestin-only pill on top of that. There's no data, but anecdotally, people do report that it's quite helpful, and it's very low risk because it's just adding a little bit more progestin. So it's actually less risk than you would get with either an NSAID or with estrogen. So depends on what you want. You could love having your period come when you want it to and not having unfavorable unscheduled bleeding, or you could be really happy because Anna says I don't want bleeding at all. I don't want it all the time, but I just don't want to ever have any. So now we're going to move on to Jennifer.
Patty, before we do that, can I just make one quick comment, and then hopefully Jolie will maybe add to what I say based on what she's doing in her own clinic. So one of the things that was on your list as a possibility to stop her bleeding was to use DMPA. But during the time of the pandemic, particularly over the last year or so, there's been quite a lot of buzz about helping people switch over to Depo Sub-Q, which is self-administered. And a number of organizations, particularly NIFRA, but the Clinical Training Center for Family Planning in Kansas City and other groups have been very proactive in helping clinics set up the possibility of teaching our patients how to do self-injections of DMPA sub-Q so that they pick it up at a pharmacy or maybe curbside in front of the clinic. They're instructed about doing their own sub-Q administration of it in an interval between 13 weeks all the way up to 15 weeks. And that way they can get the benefits of DMPA without actually having to come into the clinic. So, Jolie, have you seen much of that? Have you had much experience with that so far?
My clinic, the clinic that I work at, hasn't been quite as proactive as I might have liked on that front. But I did listen to there's an interesting podcast that the Contraception Journal kind of has a podcast, and they talked with one of the lead CIs of I think at San Francisco General. They did a study on it, and it was really interesting, and to kind of get a sense of what worked well for them, kind of what the challenges were. But I think I think about it a lot in terms of our clients who maybe had gestational diabetes and use insulin, or who have other health conditions where they're already pretty comfortable with self-injection too. That I think it's really an unexplored, it's an area sort of that I think is exciting to explore more.
Yoshi Darnell is pointing out that it's actually not known or available in most areas in Tennessee.
Yep. And also and I think that's probably the biggest barrier to it, is that it's a little bit less available in certain areas of the country. But I think there's a lot of work happening to get that to be more accessible.
Yeah. And just one last point about that before we go to our next case is that since we were talking about the medical eligibility criteria in the SBR earlier, the Centers for Disease Control is actually looking at adding more text to the section in the SPR in the DMPA chapter that gives a lot more guidance about using Depo Sub-Q. Because I totally agree with you, Jolie, that as the demand increases, there's probably going to be a lot more of it made, and it will become more widely available. And, one of the really important parts of this is that the dose of DMPA is 104 milligrams rather than 150. And there is some literature, both in the United States and from Africa, about the fact that people have fewer side effects from it because of that 1/3 reduction in the dose of DMPA. So hopefully you'll hear more about it in your area. It will become more widely available. And I think even once the public health emergency goes away and people are able to come back in the clinic, that there are going to be a fair number of people who have switched over to self-administered sub-Q. They're going to want to continue to do it that way.
Absolutely.
We had one other question that I just wanted to get to before we move on to the next case, which was sort of Rebecca asked, what's the best way to assure a patient that it's okay to not have a period, like if they're on a hormonal method? And I think that's such a great question because it comes up all the time for clients.
Yeah, and we could, Jill, you want to do a couple of role plays? Okay,
Sure.
You want to be the patient who's afraid of, one of the two things. Many people who use this, Jolie, many people who use this method either have very little bleeding or they get no period at all. How would it be for you if you didn't get your period while you were using this?
Wouldn't it be kind of weird, like if I didn't have any bleeding? Like, wouldn't it all kind of just stay inside?
Yeah, I could totally get why you would think that. And then I would pull out my pretty little picture of the lining of the uterus. Or if Jolie had said it's not healthy, or if she had said, something to do with health or the lining of the uterus building up, it's very helpful to show the little picture of the lining of the uterus and to explain and to say, yeah, you're right that if you're not using birth control that has hormones in it, yeah, it does. And you didn't get your period, that is what it would mean. But with the hormone effect on the lining of the uterus, that gets super thin. And if you're a uterine lining, thin is healthy. Jolie, many people who use this method either get very little bleeding, just occasional spotting or light bleeding, or maybe no bleeding at all. How would it be for you if you didn't have your period while you were using this method?
I mean, I think that would be great. I'd love to not get my period. It's super heavy. But I think my mom used to tell me that it was really a problem if I didn't get my period.
Your mother's completely right that if you're not using hormones, using birth control that has hormones in it, it is really not okay not to get your period. I wish that all my patients knew that when they miss their period, they need to come in and see me and find out what's going on. It's great that your mom knew that. Jolie, did you know that a lot of people using this method, they either don't get their period at all, or maybe if they do bleed, it's just occasional light bleeding or light spotting. How would that be for you if you don't get your period while you're using this?
I mean, I think I'd be okay with that, but how would I know I'm not pregnant?
I get that all the time. Yeah. And it's interesting because today in the clinic, we've had already 2 patients who came in, they thought they had their period, but in fact they were pregnant. So I know we all feel like getting your period tells you you're not pregnant, but sadly, that's not the case. Have you ever tried anything else to reassure yourself you weren't pregnant?
Well, yeah, I've taken pregnancy tests.
Yeah, well, and the pregnancy tests at the 99-cent store are really accurate. So if it's worrying you, do you think you might feel more reassured if you were getting a pregnancy test once a month?
Yeah, I think that would make a big difference.
And so on and so forth.
So I think what Patty really highlighted there is that you want to kind of find out what the concern is. Why are they worried about kind of what concerns them about not getting a period? So then you can provide information that's relevant to them. If they're worried about not knowing that they're pregnant, and you talk about the bleeding, or the uterine lining, that may not kind of connect as much. So you want to find out kind of the what is concerning to them.
Which is a generalizable principle. If your patient is concerned about something and you assume that you know what that's about before you've really gotten to the kernel of what it's about, you're going to waste time. And also it can be alienating for them to think that you're not getting it so much that you're now putting a new fear into their head that they hadn't even thought about. So you want to really get to the bottom of what's bothering somebody, what's worrying them or what's hurting them, as much as you possibly can before starting to offer any kind of solution.
Before we jump in, I was going to ask if Megan's there, if she could just give us a quick time check so we know for the next 2.
Except she said we could run over.
Yeah. To answer that, and also I was going to interrupt because you have a couple of things in the chat box, that it is 11:57. You're scheduled at 12:25, but yeah, you can run over. So you got at least a half hour left. In the chat here, I have a question. What's the best way to assure a patient it is okay to not have a period with hormonal manipulation? Oh, you already did that. I'm sorry. Okay.
We had a whole play for you. Yeah. It was 3 acts.
I'm so sorry. I had another contact going on. I'm sorry about that. Okay. Well, we've got a new one in there. You see that?
I do. Yeah. This is a good one. With patients with IUDs and the increased risk of ectopic pregnancy, are the dollar store tests still reliable for ectopic pregnancy? That's a great question. I feel like there's two things we probably want to talk about there, about the ectopic pregnancy part with IUDs and then the dollar store piece. I'm not sure if either of you want to jump in on that one.
Go ahead. Go for it.
I'm happy.
You could do one. One of us could do the other.
Well, yeah, I was going to say, I think that the really important takeaway with the risk of ectopic pregnancy with IUDs, because yes, if somebody gets pregnant using an IUD, the risk of that particular pregnancy being ectopic is higher than if somebody got pregnant and they weren't using an IUD. That is true. And the IUDs, both the hormonal and the non-hormonal, do such a good job of preventing pregnancy that your risk of an ectopic pregnancy while using an IUD is less than somebody who isn't using that method of contraception. And so I think that's a really important point, that it's not that IUDs that sort of compared to the general population or people who aren't using an IUD, you actually have a lower risk of an ectopic pregnancy because you have a lower risk of pregnancy kind of overall. So that's I was just going to highlight that with that. But then as far as the dollars,
another way of saying that is that IUDs do an extremely good job of preventing intrauterine pregnancies. They only do a fairly good job of preventing ectopic pregnancies. And therefore, the proportion of pregnancies that are in the tube in an IUD user who's got a positive pregnancy test, that likelihood that it's in the tube is somewhat higher than it would be in the general population. But you're right that that IUDs do protect against ectopics, just not as well as they protect against intrauterine pregnancies. And I'll really quickly do the one about buying a pregnancy test in the dollar store. The critical issue is that you have to read the box and find out what the threshold is. And usually the box will say that. And any home pregnancy test that has a threshold of, let's say, 20 MIU per ml or higher is going to be just as good at finding an ectopic pregnancy as it is finding an intrauterine pregnancy. Most ectopic pregnancies, even the ones that are fairly early, even the ones that are ruptured, are still associated with having HCG levels higher than 20. So for the most part, as long as the test is done correctly, and that's true of any product, irrespective of where you buy it, as long as it's done correctly, it still has a very high rate of picking up ectopics.
One thing that I think is an interesting fact about all of this is that if you were to get pregnant while you're using a hormonal IUD, your risk of that pregnancy being ectopic is about 50%. So in the general population, your risk of a pregnancy being ectopic, if you're not using any kind of hormonal contraception and not using an IUD, then you've got about a 2% chance, 1 to 2% chance. Okay. So if you look at a copper IUD, however, it's way less than a levonorgestrel IUD. Meaning that if a person were to get pregnant with a copper IUD, their chance, it's like 1 to 10 to 15. So out of for every 1 ectopic, there'll be 15 intrauterine pregnancies. So really it's still more than the general population, but it's not nearly as much as a levonorgestrel IUD. But the interesting fact about this from my perspective, when you think about it, is if you took 60,000 people like they did in a trial in Europe, and then you compare the people that had copper IUDs and the people that had levonorgestrel IUDs, and you look to see which population had more ectopics. Now remember, 50% in one population, more like 10%, 15% in another population. That's a huge difference, right? But there are more ectopics in the copper IUD users because it doesn't protect against pregnancy quite as well. Just a little difference, 0.5 percentage point difference. Mm-hmm. And that's why IUDs protect so well against ectopics, because as you both said, they're very, very good at protecting against pregnancy. And even a 0.5 percentage difference in effectiveness will yield, on a large population level, more ectopics or less, depending on which way you're going.
Portion.
Yeah, and so big take home is if you have a patient who has an IUD and they are pregnant, you really need to sort of rule out ectopic, sort of as a if someone calls and says I have an IUD and I took a home pregnancy test, you need to get them into the clinic to do that work.
Except and just to say, it's extremely rare that you're going to hear that. So,
right. Yep.
Okay.
All right. Well, here's Jennifer. Jennifer is a 33-year-old cis female, gravida 2, para 2, who is 6 weeks postpartum after a spontaneous vaginal delivery, and she's interested in a copper IUD. She's lactating and no longer having postpartum bleeding at all. On exam, her uterus is 8 to 9 week size, clearly moving in the direction of appropriate involution. It's firm and non-tender. And in the process of doing the placement of the copper IUD, during sounding, moderate resistance was felt at the internal os. And then once you got past that resistance, she sounded all the way to 14 centimeters. She complained of pain only during the initial part of the sounding procedure, but not as you were advancing the sound. So the question is what would you do at this point? Either Jolie or Patty, when you think that the sound is going way deeper than it should relative to your required bimanual pelvic exam that you do before an IUD placement, how do you evaluate that? What's next?
If I went to 14 centimeters, I would immediately stop, take out all instruments, and monitor the patient for 30 minutes. What would you do, Jolie?
I would do the same thing. Yeah, I'd be pretty worried that I'd gone beyond
the beauty of it, though, is that you make a hole in the uterus, you take out the sound, you take out you take off the tenaculum, take out the speculum, and the muscle knits up and heals beautifully, almost always.
And I think that's exactly the point. We'll talk about this as I didactically go through the slides. But no, this is not a circumstance where you get extremely worried, where you call the paramedics, where you consider doing a transfer of a patient to an emergency department and that sort of thing. It's for the most part, it's unnecessary. So let's start with a couple of definitions. A perforation, which is, of course, what we're talking about now, is a tract which is made in the muscle of the uterus, in the myometrium. Iatrogenic means that it's due to what we're doing medically. In this case, it was due to the sound going through the myometrium. And perforations, as Patty was just saying, are self-limited and are not dangerous as long as they don't go off to the side. If there's no injury to blood vessels, then the muscle just cramps down and the clotting mechanism works, and the patient does not have any bleeding more than maybe 10 or 15 cc's. Some of the other topics that we'll talk about are embedment, which is when the part or all of the IUD is actually located in the tract that you've made in the uterine muscle. And then translocation means that the perforation is through and through the entirety of the uterine muscle, and now the IUD is located beyond the uterus and somewhere in the abdominal cavity. Now, perforations are fairly rare. The old US data we had about perforation is that it happened in about 1 in 1,000 placements. There was a more recent, very large European multi-country meta-analysis that showed about the same rate of perforation, 1 in 1,000. So that's our benchmark. They are more likely to occur when the uterus is retroflexed in a posterior position, more likely postpartum, more likely in females who are postpartum and lactating. And then, of course, it has some relationship to the skill and the experience of the provider. And it's a really interesting curve in that if you're just learning how to do IUD placements, you have a somewhat higher rate. If you're after that initial training, you're at 15, 20, 25 placements, your rate of perforations go down. And then for people who do many, many IUD placements, the rates of perforation actually go up. And the reason for that is because maybe you're going too fast in that circumstance and more likely to perforate. Next.
Oh, okay.
So
I did want to point out that the 1 in 1,000 is overall, and that the rate in somebody who is postpartum or lactating is 6 per 1,000, which is still not a lot. It's just that it is relatively more. So if you're counseling somebody who's postpartum, you might want to say 6 out of 1,000. If you're counseling somebody who is not, you would quote the 1 out of every 1,000.
Agreed. So as I said, they're usually at the fundus. And in that circumstance, the perforation is going to be both asymptomatic and benign. Next slide. So how do you prevent perforation from happening? Well, always a careful assessment of the uterine position. Doing a bimanual exam before you do an IUD placement should be absolutely routine, one of those inviolable rules where you're checking, is the uterus antiflex, retroflex, mid-position, does it have an unusual shape because of fibroids? Is there any tenderness? You need to know all that in advance. Number 2, to use slow movements during your steps of the IUD placement. Avoid momentum as you're advancing instruments. Always use a tenaculum. For some reason, there's sort of a trend out there in the last 5 or 10 years of some people saying, well, you know what, it hurts to put on a tenaculum. Maybe I can get away with not using it. That, as far as I'm concerned, and most guidelines would say that is inappropriate practice. You really need the traction that comes from the tenaculum in terms of straightening out the cervical canal and the angulation of the canal. And you have to exert a fair amount of traction to do that. Other things you can do to prevent perforation is remember that the sound that you're using is malleable, it's bendable. So try to bend the sound in the direction of mimicking whether the uterus is flexed anteriorly or posteriorly, or if it's what's called axial, meaning it's straight, then the sound can be relatively straight. If you're having difficulty either having a metal sound available to you, or let's say it's in the autoclave, you can use a plastic sound, or you can even use an endometrial biopsy sampler like a Pytel. And they typically have a smaller diameter, and there may be less risk of both pain and perforation. Remember that when you're doing the sounding, to only use finger or wrist action, both with the sound and the inserter. And Patty's doing a nice job of showing you with her wrist about how you're holding the sound. You're holding it like a dart, and that you do not have movement of either the elbow or the shoulder. It's all done with your wrist, right? Okay, just like that. And then if you need to, you can brace your fingertips on the speculum to control the force while you're advancing the sound. Next.
And there are some data saying that and it's actually not published data, so it's not really fair to say, but there was one trial where somebody tried to stab holes into a uterus that had just been taken out of a patient because it was a hysterectomy specimen, and could not make holes with the plastic sound or with any of the inserters for the devices, but could with a metal sound.
Yeah.
Interesting. Somebody asked a question like about thoughts on a tenaculum versus an Alice clamp.
So at least in my experience at San Francisco General, that the Alice clamps that we had a fairly large area of bite, maybe because we use them in other clinics, for example. They could have been used more often in pregnant patients, but we found that those were actually, even though they're less traumatic, that we found that they were a little bit more uncomfortable. So in our circumstance, we still used a single tooth tenaculum. There are some rules for doing that, the most important of which are to apply the tenaculum very, very slowly and only to the first click. Okay, it's not the kind of thing you want to just like snap it on to the first or second click. Just very slow application at either 12 o'clock or 6 o'clock. Talk with the patient, some sort of distraction while you're applying the tenaculum, and most people won't have a problem with that. Other clinicians, of course, do like to put in a cc of lidocaine or some other local anesthetic at the point where they're going to put in the tenaculum. But there are a variety of other devices that are relatively traumatic and can be tried. So once you pass through the internal os, stop, pause for just a second, just for a beat. What will happen is that the involuntary muscle of the internal os will relax, and then you can proceed intentionally toward the fundus. And then the last point to make about this is that, remember, you've set the flange of the IUD inserter in advance, and you have to stop with whichever you feel first. If you feel the fundus first, you stop. On the other hand, if you If the flange hits the exocervix first and you haven't quite hit the fundus yet, then you stop. And they should, if you've done all your measurements correctly, they should hit exactly the same time. But you do stop it, whichever one happens first. And then if you're running into lots of either pain or resistance, you can either drop in a cervical block and afterwards dilate the cervix with dilators, or you can use os finders if you run into resistance. Next.
And I want to say that in that large 60-person study in Europe, which was it was prospective, observational, was a wonderful study. In that, we actually did see that people used quite a bit of, they used blocks, they used small dilators, os finders. None of these things, the people that did those and to the percentages that they did not increase risk of perforation. So we also know in other studies that being able to do a block and being able to use os finders makes your likelihood of having a successful placement go up, reach into the high 90s, which is where we really should be. You know, you shouldn't be having a 75% placement rate. You should have something in the 90s. And if you don't have these equipment, these instruments, if you don't have the ability to do a block and you don't have os finders, it's almost impossible to do that. You can't actually be successful that often, as often as we would like. So it's safe, probably protective, and definitely helps you more likely get an IUD in the person who wants one.
And I'll just jump in really quick to mention that, you know, often clients, like especially if they know people who have had like a perforation or an embedment, that they'll bring that concern in when they want the IUD, but they're worried about it. And I don't go into all the specific things that I do to kind of help prevent perforation, but I do reassure them that there are multiple things we do throughout the process to make sure we're placing the IUD in the right spot. And even just letting the patient know that can often feel it can feel reassuring that they know that you're being mindful, taking your time, doing best practices to avoid as much as possible a perforation or an embedment.
You can go past this slide next, because we've already talked about diagnosis. Okay, and then the last part about management of perforation. Oops, hang on, go back. I'll make it really fast. Okay, so if the perforation happens with the sound before you've placed the IUD, stop. And both of our panelists have said that. If the perforation happens during the placement of the IUD itself, in other words, you're sure that you've perforated, and the IUD has been deployed, better to remove the IUD because you can still get the string with that. And then afterwards, monitor the patient's blood pressure, pulse, whether she has vaginal bleeding, abdominal pain, for maybe a half hour or an hour or so, usually in the same treatment room if you have that ability. And then she can be discharged. Because again, in this circumstance, the vast majority of people do just fine. However, she's not protected. You do need to have a conversation about an alternative contraceptive method, and then you can do another try after that tract has had an opportunity to close in a month or so. Next slide.
And Mike, I just wanted to give you about a 5-minute.
Okay, I'll try to do it even faster. So variant on this is missing strings. Okay, so when you see a patient who has an IUD and they're referred to you because the strings are missing, or you're looking and you can't find the strings at the external os, basically you have to think of 5 possibilities. That the IUD is in place, but the string is coiled in the canal or the endometrial cavity, or it's a short string, or it's broken. Number 2 is she may have expelled the IUD. Number 3 is that the IUD failed. She has an intrauterine pregnancy, and as her uterus grows, it's pulling the IUD up. And then the last 2 are that the IUD is malpositioned, such that after a perforation, it's either embedded in the myometrium or it's translocated into the pelvis. Next. So just to mention in that 5 minutes, a couple of take-home messages, that if it turns out that the IUD is in the uterus, but you can't see the string, and you're going to, as you'll see in a moment, verify that with a pelvic ultrasound, the IUD is likely still working just fine. So you can leave it in place for the remainder of the IUD lifespan. We usually don't recommend, let's say, a once-a-year ultrasound, but if the patient needs that for reassurance, then that can be done just to continue to show that the IUD is in place. On the other hand, if she doesn't want to continue with that IUD in place with the string not visible, you can attempt extraction in the office. I'll say a word about how to do that. Next is expulsions. And expulsions happen anywhere between 2 and 10% of IUDs in the first year. The risk is related to, keep going, how well you did the placement in the first place, whether the uterus is distorted by fibroids, how long it's been since the placement, in that most expulsions happen in the first 6 months, the timing of the placement, because expulsions are more likely after second trimester abortions and post-placental placements. Next. All right, so sometimes the way that expulsions present is with a pregnancy. The patient didn't realize that she had expelled her IUD. Other times it will be a partial expulsion, and that's going to present with pelvic pain, cramps, intermenstrual bleeding, and actually a longer IUD string. Next. Okay, what if you do that pregnancy test that we were talking about earlier and it's positive? Well, the first step, as Jolie mentioned, is we have to differentiate, is this an IUP or an ectopic? The best way to do that is with an ultrasound. If she has an intrauterine pregnancy and she's planning to continue with the pregnancy, the better thing to do is to very gently tug on the string and remove the IUD, okay? The likelihood of miscarriage is slightly increased, but the risk is even greater if you leave the IUD in place. So if you can see the string, remove it. Next. On the other hand, if you cannot see the IUD strings, then you don't try to remove it. Counsel the patient about the risks associated with that, and she'll probably have to have increased surveillance during her prenatal care because of the fact that if you have a continual pregnancy with an IUD in place, it does increase your risk of miscarriage and later on preterm labor. Next slide. Okay, so to finish up then, in finding IUD strings, we start with sweeping the canal with a brush that we would use for doing a cervical cytology. Another trick is, if you have a colposcope, to use an endocervical speculum and look with a colposcope and see if you can see the string. And sometimes you can actually feel it on bimanual examination. Next.
You can have the person come back with their period.
Right.
Yeah.
That may help as well. Okay, so I can't walk you through this whole thing, but let me give you an idea of how this works. This is the flow chart for how to evaluate a person with a missing string if you have office ultrasound available. So you've done this initial look, you don't find it at all in the canal. All right, you start with an office ultrasound. If it's present, this is over on the left side, you see it in the uterus. If she wants to keep it, you leave it in place. If she wants it out, then you make an attempt to extract it. And hopefully it'll come out. If you pull and it just won't come, that's embedded. And in that circumstance, I'll show you why in a moment, we want to get a higher level of imaging, either with a 3D ultrasound or a CT with contrast. Then over on the other side, on the right side, if an IUD is not present on the ultrasound, then the next step is to get a KUB, an abdominal film. If you see no IUD anywhere in the whole abdomen, then it's been expelled. On the other hand, if the IUD is present in the pelvis, then you do a formal ultrasound in radiology to see if it's present or absent. Next. Okay, so here's why you get the KUB, and I know it's going to be very difficult for you to see, but hey, good, thank you, Patty. There's the IUD way up there next to the gallbladder. So that's a kind of classic case of a translocation. But here's— in that
case, you probably don't need to get a formal ultrasound. If it's clearly nowhere near the uterus.
Now, here's why in the case of an embedment, you want to do either a CT or a 3D ultrasound to help the gynecologist that's going to do the removal. Because, and I won't read all of these for you, but in some cases, the way to actually find the IUD is easier through a laparoscope. On the other hand, like in C, most of the IUD is pointing into the abdominal cavity. It's better to go after that with a hysteroscope. And rather than just guessing or doing one like the hysteroscopy first, you can't get the IUD and you go to the laparoscopy. If you do this high-tech imaging first, you're more likely to go straight to the right procedure. Next. And then the last thing I want to mention is some of the tools you can use to remove that IUD, to extract it when you when you're not seeing the string. So the best instrument to have is this one. It's called an alligator forceps, and they sometimes will come with a very slender shaft. Next. This is called an Emmett thread retriever, which is available in the United States. So with this one, you dilate the cervix just a little, place it through the os, twist it like a spaghetti fork. One of these clefts will grab the string and allow you to remove the IUD. Next. This is kind of an older fashioned approach, a slender hook that will remove the IUD. Next. And then finally, there's also evidence that using a manual vacuum aspiration will also be effective in removing the IUD. So this just gives a little bit of additional advice about how to do the extraction with the instruments that I mentioned a moment ago. Ultrasound guidance with an abdominal probe at the time you're doing the extraction usually helps, but it's not entirely required. Next. Next slide. And then the last point is the fact that if this can be uncomfortable in removing that IUD. So here are some ideas about cervical dilation with an osmotic dilator, rigid dilators, maybe even pre-treatment with misoprostol. And then in our clinic at San Francisco General, we virtually always use a cervical block with oral NSAIDs in this case, just because the manipulation can be uncomfortable.
And so you're hearing that that I mentioned that it's really important to have the ability to do a block if you possibly can, and to have os finders at the very least. An alligator forceps is another one of those tools that really should be in your toolkit if you're going to be placing and removing IUDs.
Yep, they're not very expensive. We have like 3 of them at our that are available to us at San Francisco General if we have to do 3 extractions in the morning, but they are very helpful. All right, let's move on to case 3.
All right, Patty, do you want to just keep with the slides up for and just for those purposes of time? All right, so we are going to talk about Zoe, and we're going to talk. This is an adolescent client. So Zoe is 17. She's a cis female, hasn't been pregnant before, and she has SLE. Just a little bit about her. She has a BMI of 33, and that's her blood pressure today. She's sexually active with one partner and is coming into the clinic because she wants to start on birth control. So just right off the bat, sort of, obviously we're going to talk to Zoe about sort of her preferences, but from a clinical kind of, sort of safety perspective, if you can think about sort of what concern, are there any methods that come up right away that you think might sort of not be available for her, or we'd have more concerns sort of about those methods? And we can this is actually where I think that the contraception, the medical eligibility app is a thing of beauty. Yes, Patty has some concerns. So we can go to the next slide. And this is, it's a little bit small, but hopefully you can see it pretty well. The main thing you need to know, actually, you need to get a little bit more information about her lupus, because for the most part, these are different things. These are different categories you can select within the app. But if, for example, if she has SLE and is on immunosuppressive therapy, which is the far right, you can see it's all green. Pretty much all you need to know is it's all green. That's great. So most of the methods are available to her. The main thing in this case would be if she knows that she is positive for the antiphospholipid antibodies or doesn't know, then that's where we get into that category where there's a lot more pink and a lot more 3s and 4s. And so really kind of, especially if you have patients who have more complex health conditions, the app, this is just a big old plug for the app to really help it guide you to figure out what, from a safety perspective, what people can use. Because even when people have more complex health needs, many methods are still available for them. I'm curious if either of you have any thoughts on that.
Yeah, I think one of the things that I hear from folks is that they don't know what all the little abbreviations are. So I know that Mike went through these POP, Progestin-Only Pill, the MPA, the injection, or what people call Depo, and the CHC, combined hormonal contraceptive. So that's pills, patches, and rings. So the CHC what that means is estrogen. So what that means is the person's contraindicated to use estrogen when that's a 4. And that's specifically the combined hormonal contraceptives is the category of all the contraceptives that have both progestin and estrogen in them. It's the estrogen that's giving it the 4.
Yep, and just I'll make a quick point that, like, for example, if let's say she knows that she's positive for the antibodies, other than any hormonal method is going to be a 3 or a 4 for her. So if she doesn't want to use a copper IUD, really we're going to be looking at those 3s, because especially depending on her health status, depending on the medications that she's on, it still will probably be safer to be on one of those methods than it would be to get pregnant, kind of depending on.
I think that's a great point. So you're not Zoe, you're Jolie. For Zoe, I think it's a great point that we don't want to be thinking of a 3 as something to always avoid, because a 4 is not necessarily safer than pregnancy, but a 3 is still safer than pregnancy.
Exactly. Yep. So you do your path questions, you ask your best contraception question, and after kind of, your conversation with Zoe decides she wants an implant. And you had gotten the information that she'd last had her period 10 days ago and has not had sex since then. Can you place it today?
What do people think? You guys want to do the poll?
Yes.
Or give us in the chat anybody who's like absolutely or absolutely not. Let's see if anybody comes up with anything. What do you think?
Yeah,
what do you think, Dr. Policar?
Yeah,
you're going to give this person an implant? Maybe we shouldn't give it away so soon. Let's see what people say. Oh, Yoshi says yes with 3 capital letters. A Y is capital and E is capital and S. It's a very strong yes. Yeah. Yeah, absolutely. Right. I got another Amy Hadfield says yes with an exclamation point. And we're excited. The reason we're all making a big deal about this is we really would like Zoe to get pregnant when her SLE has been addressed, right? This is not somebody that has medical equipoise. Equipoise means, the outcomes are the same no matter what she does. It's not true. She, medically speaking, should be protected against pregnancy unless she doesn't want to be, but medically speaking, it's better.
Yep. And can you be reasonably sure she's not pregnant? And so the next slide lays out kind of that, because sort of how we can be reasonably sure that she's not pregnant. And really, I just want to be clear on this. This box really tells you, can you place this without running a pregnancy test? Can you feel confident that Zoe is not pregnant? And so that, I'm not going to go through all of it, but it's just mostly, has it been less than 7 days? If she hasn't had sex since her last period, is she using another method and is switching from that? Is she using lactational amenorrhea correctly? So those are all different ways that we can reasonably know that she's not pregnant. And this is just sort of, that if you're starting, if it were within the first 5 days after her period, she would be able to start the method and, her method of choice, and she wouldn't need a backup method. It would be working right away. And, if you're starting it outside of that time frame, we really just want to make sure that we're counseling them to, use condoms, that backup method for a week. And so really kind of the, a big part of the slide deck, you can actually go on to, did you have something else?
This is meant hopefully for people to have some place to visually kind of see where they fall, see where the patient falls, and get a sense of what services to do at that point. And there are several slides in this deck that are for your reference for the future. And somebody was asking, are these slides available? Absolutely, they are. And we're going to give you a copy of the slides with a PDF, but you can also, if you want to use these slides to do an in-service presentation yourselves, we will make them available to you as well.
Somebody asked, do you consider condoms a reliable form of contraception?
What do you guys think? It is a great question.
It's a great question.
The answer is number one, how you define reliable, but if they're used correctly and consistently, then the pregnancy rate is actually fairly low. I mean, they are in the 3rd tier, the lowest tier of efficacy, but that's based on typical use, where the failure rate is relatively higher because sometimes condoms break or people put them on at the wrong time or whatever. But if they're used correctly, consistently, don't break, then their theoretical effectiveness, one would say that they're reliable. They protect
I
against
tend to agree.
STDs.
If absolutely. And I think that some of it also, that doesn't mean that you never have to run a pregnancy test. If you're, someone's like, I've been mostly, using condoms most of the time, but you don't feel like it falls into that super reliable category, then get a pregnancy test before you place that method. So then you can feel more comfortable.
And I would underline this. I agree that if somebody is using the condoms, not if it's their method that's in air quotes, like I'm on the pill, but I actually haven't taken one recently, or I use condoms are my method. I just haven't used one this month. So if somebody's actually using them is kind of the take home point. So I think it's kind of, we are all who are older are all coming from a place of a lot of paternalism with this and assuming that it's our responsibility that the person not be pregnant when we are going to do X or Y in terms of their contraception. I think we're moving much more towards, if your patient says that this is their history, then you believe them that that's their history. They are motivated to be healthy. They are motivated not to have a bad outcome. So I think that's where we're moving. If you guys agree on that one, yeah.
Yep. Agreed. And just to kind of highlight the same day placement piece, let's say if she had decided that she had wanted an IUD instead, I just want to, does she need to be on her period? No. Does she need an STD test before placement? No. The next slide kind of talks a little bit more about the STD placement piece, but pretty much, if you can be reasonably sure she's not, not pregnant, or you can run a pregnancy test and it's negative, you can feel confident in placing
the
STD,
if somebody has a history that means that they should be screened for STDs, then you can do it at the time of placement. If somebody has actual signs or symptoms of an STD currently that is in the upper genital tract, you don't put the IUD in. So it's not about whether you test or don't test. It's that if the person's symptomatic, that's one of those 3 buckets.
Yep. And then you're going to hold off until you get some more information. So you don't need that negative test prior to placement. You're going to screen them kind of based on how you'd screen any other patient. And that we know that IUDs don't cause PID. This is a big concern that sometimes people have, that there is that transient increased risk when we are placing something that passes kind of through the cervical canal into the uterus. But even if somebody sort of had gonorrhea and chlamydia at the time of placement, they were asymptomatic, we didn't know it, you can sort of treat with the IUD in place. And same thing with PID, just with a little bit closer monitoring. So that should not be a barrier to getting somebody sort of their method of choice that day, if that's what they want. And so she's excited, like she can get an implant that day. She came in, she picked her method, she can get it that same day. Sort of, she asks, how long can she use it for? What are you going to tell her?
Well, that depends on where I'm working. So there are data saying that it is really, really fully effective through 4 years and probably through 5 years. And the reason I say, depending on where you work, some places have it in their protocols that it's good for up to 5 years. And some places have it in their protocols. You must not do anything in terms of length of use that's outside of the FDA indication. And the implant is FDA indicated for up to 3 years of use. And so if I'm working at Planned Parenthood, I will use their protocol, obviously. So I am comfortable, though, having extended use to what we know scientifically to be the length of time it will be effective.
And I'll just mention, like, the clinic, the FQHC that I work at, for a long time there was resistance to moving towards that extended use, and actually it was the pandemic that helped push us forward into accepting that extended use. So I'd say if you're working somewhere and there's still been that resistance, this could be a good time to revisit the conversation to allow patients, that extra time to not have to come in if they're not feeling comfortable coming in because of what's going on in their communities. And then I think we will wrap up with something actually that is very near and dear to my heart with counseling, which is talking about sort of removals. Do we have the next slide, Patty? So somebody, let's say, she comes back and, in 4 months, 5 months, and she is not happy with the bleeding. She's not happy with mood swings. She's whatever fills in the blank. She's thinking about pregnancy at that point. It doesn't really matter. If somebody comes in and is requesting a removal, I think it is really important that you begin the conversation by assuring them that you will remove that device for them that day if that's what they want. That doesn't mean we don't ask some follow-up questions to find out if there's something that we can do to help them manage like the side effects that they're having or the bleeding patterns that they're having. But we lead with, you are coming in requesting this thing, and I will do that today for you, for you as a leading point, because it changes the whole dynamic. People are often much more open to talking about the things that aren't working for them if they don't feel like they have to defend and be, kind of be in that kind of adversarial relationship with us as you're withholding something that I want. And so I'm going to orient towards the idea that I'm going to convince you why I need to have this out. And so sort of leading with that and then transitioning to, can you tell me a little bit more about what hasn't been working for you with this method and going from there. But I just, really want to exclamation point that, because I think if we are talking about same day placements, we also ideally need to be talking about same day removals, because there is that power differential with these methods. And as providers, we have the power to place these methods, and we also kind of hold the power to remove them for our clients. And something that's a part of my practice, and I think this is our last slide, and then we'll let you all get some food, is that when I place an IUD or I place an implant, I always talk about the method being good for up to a certain amount of time. So we now know that the 11-agestrol IUD works for up to 6 years. But if for any reason you want to get pregnant, or tripping over my words, but if you want to get pregnant before that, or you want it out for any reason, we will remove it for you. And I think setting that kind of as the expectation from the moment people get these LARC methods placed is really important. And if future fertility is something that kind of either you're not sure or that is a concern for them, kind of adding in in your ability to get pregnant.
And a lot of times that return to fertility comment is really medicalese. And so saying your ability to get pregnant, that's return to fertility, right? It goes back to whatever's normal for you. So this is just another example of using language that is, the only thing I wanted to add to what you were saying, Jolie, is that some folks have said it's very helpful when they're initially counseling clients that are going to be getting an IUD or an implant that day, that if they are going to be going to a different clinic, to emphasize that it really is their right to get it out at whatever time they want it out. And one idea about that is actually to coach them to saying, I am really uncomfortable with this. I really would be much more comfortable if you would take this out. Or it feels, there's a great way to say it. It feels very important to me. Or something where they come up with a phrase that is extremely comfortable for them to say to their healthcare provider, that will ensure that there's not a negotiation that's going to happen. Because that's essentially where we have been coming from with this for quite a while, is that we think we're supposed to negotiate with the patient to keep it in.
All right. And I think that's the end of the end of this.
So much to Patty and Jolie and Michael for those case studies today.